Thank you. I will be presenting evidence of phase 3 randomized control trial where ecotinib, which is a first generation TKI available in China, is compared with chemotherapy as adjuvant treatment for stage 2, stage 3A EGFR mutant NSCLC. Next slide, please. Background. So, operable lung cancer, as we know, has high risk of recurrence. Even for stage 2 and 3A, the risk of recurrence is significant. Adjuvant chemotherapy has a definite role in stage 2 and 3A, which has been shown in even in meta-analysis. Adjuvant TKI in EGFR positive patient has never been compared to adjuvant chemotherapy in randomized fashion, uh, especially ecotinib, which is first generation TKI in China. We have some data for erlotinib and geftinib, and now we have data for osimertinib, but that is chemo followed by TKI versus placebo in ADORA. So previous studies with geftinib have shown TKI has better disease-free survival and lesser adverse events compared to chemotherapy. But from what the data is there for ecotinib, it seems that it is better tolerated than geftinib. So here they have tried to compare ecotinib versus adjuvant chemotherapy. So adjuvant ecotinib for 2 years versus adjuvant chemotherapy around 4 cycles. Next slide, please. So patient included were 18 to 70 years. Patient 8 weeks post R0 resection of tumor, EGFR exon 19 or exon 21. So the standard mutations were taken. Stage 2, stage 3A patient with good performance status of 0 or 1. The randomization was 1:1 and it was stratified according to stage 2 versus 3A, EGFR mutation type exon 19 versus exon 21, type of surgery, pneumonectomy versus lobectomy. And randomization was to 2 years of adjuvant ecotinib versus 4 cycles of vinorelbine cisplatin or pemetrexed cisplatin. Next slide, please. So they followed up the patient with CCT thorax and USG abdomen pelvis every 12 weeks in first 2 years and every 24 weeks in year 3 to 5. Brain imaging and bone scan were done every 48 weeks, and if there was clinical indication, this imaging was repeated in between. Primary endpoint of the trial was disease-free survival, and secondary endpoints were 3-year disease-free survival, overall survival, safety, and quality of life. Next slide, please. So as we can see that disease-free survival is significantly better with ecotinib. Median is 47 months versus 22.1 month in chemotherapy harm with hazard ratio of 0.36, not nearing unity. The confidence interval is 0.24 to 0.55 and with a very significant p-value. Next slide, please. And this is seen across all subgroups, irrespective of clinical stage, irrespective of mutation type, irrespective of type of surgery, lymph nodal status, smoking history, age, sex, or performance status. So overall, all the subgroups are benefiting significantly with adjuvant ecotinib, but this is for disease-free survival. Next slide, please. The secondary endpoint 3-year disease-free survival was 63.9% versus 32.5% with chemotherapy. Overall survival data is immature. There were only 9 events in both the arms, so it is too early to say on overall survival. Quality of life was similar at 36 weeks in both the arms. Next slide, please. So the toxicity pattern, as we expect that there were more skin, nail changes and diarrhea with TKI and chemotherapy, there were more cytopenias. Obviously, chemotherapy toxicity was for 3 to 4 months, while for ecotinib it was for around 2 years. So the duration of toxicity is also important when we are giving adjuvant treatment. Next slide, please. So my take, I think for this adjuvant studies, overall survival is a better endpoint than disease-free survival. ADORA design is better strategy as adjuvant chemotherapy is known to have overall survival advantage. So why not to give chemotherapy followed by adjuvant TKI? Osimertinib has more CNS activity, and most patients in this study who were on chemotherapy arm, most of them, around 45 to 50% of them have failed in brain. So osimertinib being more CNS active drug and most tolerable TKI amongst the one which we have used in first generation, second generation, third generation, I think that would be a better idea to give as a adjuvant treatment compared to other TKIs. And this all is, I am assuming that it will have overall survival advantage. And one more debatable thing is duration of adjuvant TKI. So there are studies with 1 year, 2 years, and 3 years. We don't know how long to give. So whether to give TKI as a sequential thing versus adjuvant, whether adjuvant or first line metastatic setting is something which is still debatable. Until we have overall survival data, we won't be able to uh, have the clear cut answer on it. Thank you.